Good morning. I would like to thank the organizer for inviting me to give this talk. It's my second talk during this meeting. I'm very glad to be here, and it's a great experience as I did last year in Odisha. So this is the agenda of my presentation. I will mention very quickly about the epidemiology of HCC, which are the moment the standard of surveillance for HCC, the new scores, and liquid biopsy. Regarding the epidemiology, we know that liver cancer is the 6 months common cancer worldwide, with 8.3% of all cancer deaths in 2020, and HCC being the most often against the background of chronic liver disease. In this slide, published last year by Amit Singhal in Nature Review of Clinical Oncology, they show the annual risk of HCC in patients with cirrhosis stratified by according the major etiology underlying. And as we can see, it's confirmed that metabolic liver disease is becoming the most common etiology in hepatocellular carcinoma. What about surveillance? What is surveillance? What we want to do with the surveillance? We need the surveillance for an early detection of liver cancer, that this can facilitate the receipt of curative therapy. So the main scientific societies around the world are suggesting which are the categories that should underway the surveillance, as patients with the SILE A and B, and also patients with SILE C that are awaiting liver transplantation, and mainly all the patients, or most of them, with chronic hepatitis B carriers and having different backgrounds, and those patients that have a family history of HCC. How are we going to do that? At the moment, we do ultrasound every 6 months, and in some scientific society it has been suggested to use also alpha-fetoprotein. All of this has been done every 6 months. Then, of course, there are some pros and cons about this technique. So if we look what is the proportion of detected HCC comparing patients that underway only the ultrasound compared with those that also have AFP, so the combined US and AFP, the number of detected HCC increasing, in particular those detected via the surveillance. So this is good news, and the number of those detected symptomatically, that means that the diagnosis is done because there is some symptoms. This is decreasing using both of the techniques. This is a meta-analysis published a few years ago with the Cochrane, where using only alpha-fetoprotein, that we can also consider a biomarker, because it's the first biomarker used in clinical practice for the detection of HCC. There was almost 40% of HCC that were missing, and using only ultrasound, there is more than a quarter of the HCC that is missing. So if we combine both of them, there is a higher sensitivity that so only 5% of HCC will be missing, with about 50% of false positive. So confirming that the combined technique is much better. What the future new HCC guidelines done by EASL will say. This has already been spoiled during the meeting in Milan this year in June, but are not published yet. So we will say that every 6 months we need to have ultrasound, and the combined use with AFP will increase the sensitivity, even there will be just a low decreasing of the specificity of the both of the technique. And then we will mention also the possibility of using the abbreviated MR. I think it's been already mentioned during this meeting, and the possibility of using biomarkers. But at the moment, we cannot be suggesting both of them. So, of course, as we said, the US and AFP are the most cost-effective for HCV surveillance. However, both of them have limitation. We know that ultrasound is very highly operator dependent. There is a worse performance in patients with obesity. There is a poor sensitivity of detection of HCC in the early phase versus dysplastic nodules. And regarding AFP, is expressed also in other conditions as inadequate on its own sensitivity and specificity, and there is a low positive predictive value. So the other point that I would like to point out is the suboptimal surveillance around the world. This data comes from the United States, but are confirmed also in other parts of the world. And as we can see from this data published a few years ago, in the casuistic that they analyzed the period between 6 and 12 months, 12 to 24 months, and over 25 months. So what they are saying that almost 50% of patients did not receive any radiological technique in this period. So that means that mostly, or at least half of our patients, they do not receive any radiological technique, so they do not follow any surveillance, and this is very risky for developing of HCC. So which are the solutions? In this paper published recently by the group of Ruit Lumba, they try to suggest some solution, and what we will look for are the risk factors, the biomarkers, and the liquid biopsy. What about the scores? Why we want to score? We want to stratify patients, because otherwise there are too many patients to be screened in, with cirrhosis. So we want to find which patients have the higher risk to develop HCC, the moderate risk to develop HCC, and the low risk to develop HCC. Which are the most typical example? We know that there are different scores that we have been using. I think that these have already been mentioned during the last days. Those used in patients with HBV, and the most used score are the MPHB, the ASL-HCC, the CAMD, and the REAL-B, where they outperform very well in all the timing that we've been used at 26 weeks after the start of the antiviral treatment, 52 weeks, 78, and after 104 weeks after the start of the antiviral treatment. The other score that we have been using, we published this paper with the group of Vienna, is a multi-center paper in patients who were eradicated by hepatitis C, and we could, taking just a one-time assessment of at 12 or 48 weeks after the eradication, we use very simple molecules like alpha-fetoprotein. We then use some characteristic of the patient with age, the fibroscan, albumin, and we also collected the data about the alcoholic consumption. And we could make a stratification between the high risk and the low risk. In this way, we can exclude those patients with the low risk from the surveillance, and this means having a really less number of patients needs to be surveilled. But what about the scores? One of the first scores was published by Elsrag about 10 years ago, and they've been using as markers, again, alpha-fetoprotein, because, again, as I said before, in my opinion, alpha-fetoprotein needs to be in all the scores that we are going to use, because it's very easy and it's very common in all around the world. Then they checked also for the rate of the change of alpha-fetoprotein, the age, the transaminase, and platelet. And as we can see from the different figures, this is predictive when the transaminase are low. So the higher are the transaminase, the lowest is the predictivity of this score. And then they compared patients with 50 age and 70 years old age with platelet and the transaminase again. And the best predictive role comes from when the platelets are high and the transaminases are low. That means to be a less advanced liver disease. But there are also other scores. One of the most common is the GALAD score, using the gender, the age, and then three markers as alpha-fetoprotein L3%, and DCP. These three markers have a considerable discriminatory ability for distinguish by HCC by chronic liver disease, as we can see, and they compared with the model with the single three markers, having a ROC curve much better than with the single one, having so much more specificity. What about the GAD score? The GAD score is something that is been using in India. I think it's only been used in India, and they made a comparison between something, some data that the clinician can order through a website, or you can send the samples, and they will cover some laboratory stage, and they will give you the results to the physicians. So they compare these two methods, and they did the development cohort and the validation cohort, and in both of them, the early stage of HCC, the GAD score performed better than the single markers, AFP and PIVCA, and in both validation and development cohort. So it seems that it's working quite well. What about the new HES score? Is the one that was published in 2014 by Elsrag. So they made some news, and they combined this, and they made evaluation versus other scores, and this new HES-V2 seems to outperform the GALD score and the previous score. So there are many scores that can be used. Of course, I'm not talking about how much does it cost, how much it comes, and how it will work in the future. But in my opinion, having a biomarker and mixed to the score, it could help a lot. What about liquid biopsy? Why we need the liquid biopsy? Because there is an estimation that we can implement of 40% the rate of the early diagnosis of HCC. But what is a liquid biopsy? Liquid biopsy means that in the blood we can have some products that we can collect by some specific markers. So we know that HCC is a low mutational burden. These are all the main driver somatic mutation, and part of this mutation can be found thanks to the cell-free DNA between almost 50% and 80% of these markers. So this is the way we can use the biomarkers and the liquid biopsy. One of the most interesting paper was this by Kai, where they used the genome-wide mapping, the 5-hydroxymethylcysteine in circulating DNA, and using as a non-invasive marker. And they found again that compared with other scores have a quite good sensitivity in both validation and clinical group of patients. And then there is this novel multi-target blood test. They used a 10 reported methylated DNA with associated with different proteins, between these of course also alpha-fetoprotein. So the sensitivity for the early stage was more than 70%, with the specificity almost the 90%. They use also validation core with an overall survival, overall sensitivity was quite well. The good thing is that the early stage sensitivity in clinical validation was higher than alpha-fetoprotein and greater than the GALAD score, but the specificity was a little bit lower than the compared. So if we go back to the paper that it's been showed before already, the number of patients that have been detected adding also the multi-target and adding also the improved adherence is almost arrived at 50%. So we started with only ultrasound that was not 40%. So this is a good increasing. This is another recent paper published in Lancet recently by a Chinese multi-center study, where they also used other scores that can increase the number of patients with the early detection of HCC. And then very quickly I will show just the last two slides, one with the extracellular vesicles that expressing annexin V, expressing EpCAM, SGPR1 and CD11133. They suggest some algorithm, and they are suggest that can be very good in diagnosis, the early diagnosis of HCC and also cholangiocarcinoma. And the final one is regarding the non-coding RNA. They used in this other Chinese group the 7 Myrna classify, showing that it can be used, it can have a detection of HCC even a couple of months before the clinical diagnosis of hepatocellular carcinoma. So in conclusion, effective stratification improve HCC surveillance by identifying high-risk individuals for early intervention. New tools and strategies are urgently needed to enable more effective HCC screening. Existing risk scores vary in effectiveness. Ongoing validation and refinement are essential. Liquid biopsy offers a non-invasive, accurate method for early detection surpassing traditional imaging. Combining the liquid biopsy with current methods enhances early detection and personalized monitoring. Of course, we need food research to confirm this data. I would like to thank again the organizers and remind you that next year we will have the Steatotic Liver Disease Summit in Portugal, end of January, the Liver Cancer Summit in end of February, and of course the annual meeting of the EASL in May in Amsterdam. And we welcome all of you. Thank you for your attention.
Thank you, Professor, for that excellent talk. And the topic is open for discussion.
Thank you very much, sir, for this excellent talk. Sir, here. So my question is regarding non-cirrhotic HCC. So are we there for surveillance? And if yes, what should be the surveillance strategy in a non-cirrhotic background? We know that, NASH and MASLD, we are getting those big HCCs which are diffuse kind of an infiltrative lesions, and it's usually picked up late. So any strategy for a non-cirrhotic HCC?
Very good question. Mostly of these scores that have been used, as you know, they've been used in patients with viral hepatitis, mostly of all the casitic. Even there are some casitic where they use also non-viral hepatitis. Regarding the patient with metabolic liver disease that, as we saw in the second slide, that are the ones that have the highest in the future possibility to get, we're not there yet. I mean, the patient who has cirrhosis, of course, due to MASLD, they of course need to be followed. And then the other thing is what background they have. So, for example, African people or people that come from certain areas of the world, they need to be followed more strictly than others. But of course, patients with cirrhosis and MASLD, for sure, they need to have a screening. And I hope that we will have some score also in this category of patients.
So I have a question for you. And regarding the ultrasound-based criteria for diagnosing of SCC, based upon the nodular size, they have been taken into account. Along with the GARD score and Gallard scoring, they'll be taking. What is the implication to look at that? So whether you are doing that scoring biannually or quarterly, what is the area of assessment? What is the cutoff criteria being taken into account to screen the patient is having prognostic implications in HCC, sir?
So I didn't understand the last part of the question. Which score are you speaking about?
About your GARD as well as your Gallard scoring system, along with your ultrasound size of nodular assessment, they'll be using various implications. What is your...
you mean nodular? How big are the nodules?
Yeah, nodular size of the lesions. So for example, 1 centimeter, more than 1. So what is the cutoff you have been taking every quarterly or assessing or biannually or assessing? What is the criteria you have been taking into account, sir?
Yeah, one of the slides that I showed was, in my opinion, we need to look at hepatology, and in this case, a single case by case. I mean, we can generalize as we saw. We need to understand which are the ones are the most highest risk of developing HCC. And for example, a patient who has suspect nodules with some suspect of cancer, they need to be even quarterly, as you were suggesting. Generally speaking, I wouldn't go more than 6 months. So every 6 months, it's good. But when you have some risk, even less than 6 months could be the best way. Also for the markers. I mean, at some point when these biomarkers will be sustainable, because at the moment they might cost too much, some of them, for example, Myrna or extracellular vesicle. But when this will be sustainable, maybe we can even use more frequently than twice a year.
And what is your opinion about exosomal assay as well as your ctDNA in liquid biopsy? What we are going to look into that?
So I didn't show because we have some data in our center. We have been comparing patients with chronic liver disease, early chronic liver disease, advanced chronic liver cirrhosis, and cancer. And we were not, this is cell-free DNA. we did not have that great results, but these are just our first. The problem is that sometimes you are not able with the techniques that we have at the moment. We are not able to find the right mutation. So there are some papers actually that are trying to increase the mutation. There is a paper published in Science recently that trying to increase the mutation or increase the detection of the mutation. So that might be the future. So if we will be able to increase the percentage of mutation, we might be able to use this. But at the moment, in clinical practice, I'm not very sure we can go and use this.
Thank you.